Dr. George W. Sledge, Jr. is Professor of Medicine and Chief, Division of Oncology at the Stanford University School of Medicine and co-director of the Stanford Cancer Institute's Translational Oncology Program. Trained in internal medicine and medical oncology, he has devoted his professional career to understanding the biology and improving the treatment of breast cancer. He is active as both a laboratory and clinical researcher with more than 380 scientific publications. He is the recipient of numerous scientific awards, and his research interests have focused on novel biologic approaches to breast cancer therapy. Ladies and gentlemen, please welcome Dr. George W. Sledge, Jr.
Well, thank you for that exceptionally kind introduction. It's a delight to be with you here today. My congratulations to the Bay Area Cancer Connection for holding this in such trying times, and my gratitude to all of you for being willing to listen to me today. First, some disclosures. What I was tasked to do today was to talk to you about management of early stage breast cancer. And I'll be speaking a little bit about local control of the disease, but mostly about the distant aspects of the disease. How do we prevent a recurrence, and how do we prevent women from dying of a distant metastasis? But let's start here with some very simple biology. If we look at early stage breast cancer, one of the things that we've discovered a long time ago is that most breast cancers start in something called the terminal ductolobular unit. The lobules are the portion of the breast where breast milk is made, then flowing through the duct toward the nipple-areolar complex. And most breast cancers, we now believe, begin somewhere in this particular area. And as I'll show you in a minute, the most common types of breast cancer have a fairly different and distinct looks about them. So when we look at what happens in early stage breast cancer, one of the things that we've known for a long while is that the initial step from a normal breast to a breast cancer frequently occurs inside the milk duct, where cells pile up inside the milk duct, typically with some hyperplasia or overgrowth. Subsequently, they become more malignant looking, and at that point, we have what we call a ductal carcinoma in situ, shown in the lower left panel. And then eventually these cancer cells will invade outside of the milk duct into surrounding tissue, at which point we have an invasive or infiltrating ductal carcinoma, or if it's in the lobule, an invasive lobular carcinoma. Now, as I'm sure most of you know, we can frequently pick up most, though not all, breast cancers through breast imaging techniques, such as screening mammography. This is a classic breast cancer mammography look with clustered microcalcifications. A radiologist looking at this would say that this is a BI-RADS5 or high risk for having breast cancer, and would encourage a biopsy of this. Mammography recommendations have come out from a number of different sources. This is one from the United States Prevention Services Task Force, and it's a fairly standard one, recommending screening mammography every 2 years for women between the ages of 50 and 74. And in women before the age of 50, an individual decision when to start screening mammography every 2 years based on discussions with a physician. The task force does not recommend screening mammography for women over the age of 75 and has no recommendations regarding breast self-examination, though certainly most of us would encourage this. Now, once we have a suggestion on screening mammography or perhaps on physical examination of an abnormality, we then proceed to doing the biopsy of the area of concern. The most common form of biopsy today is a so-called core biopsy, shown in the upper right part of the breast. This allows one to get adequate amounts of tissue to look at the histology of the cancer and to do special stains if it is malignant. Other approaches have been used, but certainly core biopsy is the standard today. Now, when we get a core biopsy and we look at it under the microscope, or if we get subsequent breast tissue and look at it under the microscope following surgery. The most common types of breast cancer are shown here. On the left, an invasive ductal carcinoma. These cancers represent somewhere in the range of 2/3 to 3/4 of all breast cancers, though there are a number of subtypes of this. And then on the right, invasive lobular carcinomas, which represent a smaller proportion of cancers. The ones on the right, the lobular carcinomas, are distinctive in that the cancer cells tend to line up in so-called single filing that one can see under the microscope. Now, once we've gotten a biopsy, pathologists will look at the tissue and then we'll come to a number of different conclusions about what they're seeing. Is this invasive or not? In other words, has it escaped from the milk duct into the surrounding tissue? What type of cancer is it? And I mentioned the ductal and lobular, but there are a number of other types. What we call the grade of the cancer, and grade can be thought of basically as how ugly does the cancer look under the microscope. Is the cancer driven by estrogen? And that is to say, is it estrogen receptor positive and or progesterone receptor positive? Or alternatively, might it be driven by something called HER2, another growth factor receptor? Can we tell how rapidly the cancer is proliferating through the use of something called Ki-67? And finally, particularly for estrogen-sensitive cancers, can we get a better handle on how aggressive the cancer is with genomic assays such as Oncotype DX or MammaPrint? Having done all this, we now have to make an initial decision regarding what sort of therapy the patient will receive in terms of local therapy. And this typically will involve either breast-conserving surgery or mastectomy. Breast-conserving surgery is shown here with a lumpectomy where one removes the cancer in a small rim of normal tissue around the cancer. At the same time, whether or not one has a lumpectomy or a mastectomy, we also typically will perform a sentinel lymph node biopsy, where one injects a dye into the breast. This tracks to the nearest lymph nodes. We'll remove those lymph nodes and see whether or not they have cancer involved in them or not. If there is no cancer in the sentinel lymph node, then one's all done. If there is significant amounts of cancer in a sentinel lymph node, the patient may require further therapy in terms of more extensive lymph node surgery. Now, after breast-conserving surgery with a lumpectomy, typically the patient will also receive radiation therapy. We know that this reduces the risk of local regional recurrence, and by doing so also appears to reduce the risk of distant recurrence. In patients with advanced breast cancer, radiation is palliative, but today we're talking about early stage breast cancer. Now, many patients who have a mastectomy, particularly if they have a large cancer or a cancer that has invaded the skin or chest wall, will also be receiving radiation therapy. Now, once one has done local regional therapy, be it a lumpectomy or a mastectomy, with or without radiation therapy, we then proceed to ask the question, should the patient receive systemic therapy for early stage disease? And by systemic therapy, we mean therapy that's given to the entire body, the entire system. And our decisions to do this are based partly on anatomy, but increasingly on the underlying biology of the cancer. And the systemic therapy that we give may be either so-called adjuvant therapy, therapy that's given subsequent to surgery or surgery and radiation therapy, or maybe preoperative or so-called neoadjuvant therapy given before one ever does surgery with the idea of shrinking the tumor. Much of our decision matrix is based around what type of breast cancer we have. And probably the most important thing that we've learned in breast cancer in the last generation is that breast cancer represents a family of diseases. The majority of breast cancers are estrogen sensitive, and that's to say they contain an estrogen receptor that helps drive the growth of the cancer. But as I had mentioned earlier, there's a smaller population of patients who have a growth factor receptor called HER2, and then a third group of patients, representing perhaps 10 to 15% of patients, who lack receptors for either estrogen receptor or for HER2. And these are called triple negative breast cancers, though one may also hear the term basal cancers. So let's go through each of these, because knowing about this also tells us a great deal about which therapy a patient should receive. So patients who have estrogen-sensitive breast cancers have tumors whose growth is driven by estrogen that is floating around in the patient's blood. This estrogen freely crosses into the breast cancer cell, binds there to an estrogen receptor, goes into the cell nucleus, and there binds to DNA and tells, in essence, tells the cancer cell what to do. And much of what is being done is to tell the cancer cell to divide. Now, there's a number of potential attacks on this that we've been using for quite some time. The two most common, particularly in postmenopausal women, are antiestrogens, such as tamoxifen, or alternatively aromatase inhibitors. And there are 3 of these aromatase inhibitors. Today, we use tamoxifen relatively more commonly in premenopausal women. Aromatase inhibitors only work in postmenopausal women. If we look first at tamoxifen, because it was the first endocrine therapy we had for early stage breast cancer patients, dating back to the late 1970s, we have very long-term follow-up. And what we know is that 5 years of tamoxifen gives one improvements in terms of reducing the risk of distant recurrence and reducing the risk of mortality as far out as we can measure. And as far out as we can measure is now approaching 20 years. Tamoxifen works best in women who have the strongest estrogen receptor status. But you'll notice from these curves that there are still many women who will suffer a recurrence and will go on to die of their disease. So this is not a solution to all breast cancers, though it certainly has been beneficial to many women. Now, beyond tamoxifen, starting with the discovery or use of aromatase inhibitors starting in the 1990s, and then the adjuvant trials that were done in the mid-2000s, we had evidence, particularly in postmenopausal women, that giving an aromatase inhibitor compared to giving tamoxifen could further reduce the risk of distant recurrence and further reduce the risk of death. And indeed, if we look at the advances we've made over the last 40 to 50 years, one would say is that 5 years of an aromatase inhibitor reduces breast cancer mortality rates a decade out by about 15% compared with 5 years of tamoxifen. And so if you add up the benefit that we had received previously with tamoxifen to the benefits that we see with aromatase inhibitors, we get about a 40% proportional reduction in the likelihood of dying of breast cancer compared to getting no endocrine therapy alone. Now, proportional reduction can be fairly confusing, but let's say that a woman has a 20% absolute risk of having a recurrence of her breast cancer over a decade's period. Giving an aromatase inhibitor for 5 years will reduce this by about 40%. In other words, from 20% down to roughly 12% for the average woman. Now, we still have progress that needs to be made, and researchers have been looking extensively in terms of new potential therapeutics for early stage ER-positive breast cancer patients. A recent advance in the metastatic disease setting involved what's known as CDK4/6 inhibition. And the biology of this is a little confusing, so follow with me briefly. But after estrogen binds to the estrogen receptor, it stimulates a number of things that lead to cell division. And in particular, what are called cyclin-dependent kinases 4 and 6, or CDK4 and 6. And through this somewhat complex pathway, this kicks the cancer cell into division, so one gets dividing cells, such as we see in the left-hand panel. Now, knowing this, researchers were able to come up with novel compounds, novel drugs that would inhibit CDKs 4 and 6. And these have now been brought into the clinic, initially for patients with advanced breast cancer, but very recently for patients with early stage breast cancer. And this is fairly hot off the press news. This is a little over a month ago now at the European Society of Medical Oncology meetings, a very large trial of patients with high risk estrogen receptor positive early stage breast cancer. And in this trial, patients either had a bunch of lymph nodes, 4 or more lymph nodes involved, or had a smaller number of lymph nodes involved, but had another risk factor such as large tumor size, high-grade tumor, or a rapidly proliferating tumor. These patients were randomly assigned to receive hormonal therapy alone, of the standard sort that we've been using for years, or to receive hormonal therapy plus abemaciclib, which is one of the 3 CDK4/6 inhibitors that's on the market, with a primary endpoint of looking at the patient's likelihood of having invasive disease. Now, if we look at the initial results of this trial, and this trial has very short follow-up, not quite a year and a half of follow-up at this point when this was presented last month. What we can see is that already with very early follow-up, we're seeing a reduction in terms of the risk of invasive disease by roughly a quarter. This trial needs much further follow-up, but this has already reached what physicians consider a statistically significant result. And this may soon lead to the approval of this agent by the Food and Drug Administration. We'll have to wait and see. But this is the first major advance we've had in the last 15 years or so in the setting of ER-positive breast cancer in terms of novel therapeutics, and certainly one that we're very positive on. The top-line results from this trial are shown here. Again, as I mentioned, fairly short follow-up, and not many patients have completed the 2 years of therapy mandated by the trial. These drugs have real side effects and certainly need to be discussed by a physician with a patient. But they also significantly improve disease-free survival and what we call distant relapse-free survival. And again, in a potentially important improvement, albeit with fairly short follow-up. This trial is immature in terms of overall survival, so we don't know yet what this is going to do in terms of preventing death due to advanced disease, though we're certainly hopeful that this may represent a step forward. Now, we have a big problem in ER-positive breast cancer, and that is to say that we've known for a long time that giving chemotherapy can lower the risk of recurrence and death in ER-positive breast cancers. But we also know that most patients who have ER-positive breast cancer simply don't benefit from chemotherapy. So we're overtreating many patients, or at least in the past, we're overtreating many patients to give a relatively small absolute benefit. And this was a source of angst for both physicians and patients for quite a long time. Now, starting about a decade and a half ago, we started to have new assays such as Oncotype DX and Mammaprim, the two most commonly used ones in the United States, where we could take pieces of the tumor, slice and dice them, do a genetic analysis on them, and see the relative amounts of particular genes that we know are involved in cancer proliferation, estrogen-mediated growth, metastasis, and the like. And using an algorithm shown on the right, and I promise not to go through the math with you, we can actually determine which patients are at relatively lower risk and those who are at relatively higher risk for having a recurrence of their early stage estrogen-sensitive breast cancer. And this is a continuum. So the higher one's recurrence score, the greater the risk of having a distant recurrence of breast cancer. Now, early studies of this were not randomized trials, but rather trials looking at relatively small number of patients. These trials suggested that patients who had what we consider a high recurrence score had a pretty high risk of eventually developing a recurrence of their breast cancer. Roughly a little over 1 in 4 patients at 10 years would suffer a recurrence of their breast cancer. In contrast, patients with low recurrence scores appeared to have no increased risk. Initially, we weren't quite sure about patients with intermediate recurrence scores, and this led to the development of a very large phase 3 trial that I had the pleasure of being involved with. And this trial now has relatively long-term follow-up and looking at endpoints such as what we call disease-free survival, the likelihood of either a local or a distant recurrence, or looking at distant relapse-free survival. What we now know is that if one has an intermediate recurrence score, and if one is postmenopausal, there doesn't appear to be any real benefit, any benefit at all, for adding chemotherapy to hormonal therapy. Now, armed with this data, we've been able to actually reduce the percentage of patients who need chemotherapy in early stage ER-positive breast cancer patients by somewhere on the order of 70 to 80%, a major advance. We've been able to avoid a lot of toxicity of therapy as a result of this. There are some nuances to this. Younger women of the age of 50 who have an intermediate recurrence score, some of these women may still benefit from chemotherapy. But in general, for the majority of women, we can actually rule out the need for chemotherapy in a substantial proportion of patients. Now, let's move on from estrogen-sensitive breast cancer to HER2-positive breast cancer. By HER, we mean something called human epidermal growth factor receptor. And these are receptors where on the cell surface, part of this receptor sticks out and will bind proteins that are signaling proteins inside, the receptor will then signal to the cell nucleus and tell it to divide. And HER2, the one that we're interested in, is part of a family of receptors that are important, not just in breast cancer, but in many other cancers as well. We can measure these in the clinic using either what's called immunohistochemistry or something called fluorescence in situ hybridization. This is fluorescence in situ hybridization, where one measures how many copies of a HER2 gene there is in the cell, and then compares that to how many copies of the chromosome that HER2 is on. And we see whether or not the cancer has amplified HER2 or not. If it does, that suggests a patient who's likely to benefit from HER2 targeted therapy. And we've learned, as a result of studies done in HER2 positive disease, that these receptors bind to each other, and it's in the binding to each other that they stimulate the cancer cell to grow. And most commonly, they bind with something called HER3. Now, we had learned all this quite a while ago, but it wasn't until around 2005 when we had the first large studies of early stage breast cancer, HER2 positive disease, where we were able to look at whether or not a HER2 targeting drug, the antibody Trastuzumab, would have any effect. And indeed, it had a particularly profound effect, roughly having the annual odds of recurrence for a patient with a HER2 positive breast cancer. This got us closer to our goal of curing patients with HER2 positive breast cancer. But as you can see from these curves, there's still many women who suffered a recurrence. And so while this was a major advance, and indeed the first major advance we had ever seen in this particular type of breast cancer, we knew that we still had work to do. And one of the questions that we wanted to ask was, because our initial trials involved fairly aggressive chemotherapy given along with trastuzumab or Herceptin, could we actually get by with a little bit less, particularly for patients with smaller breast cancers or lymph node negative breast cancers? So this led to a trial of over 400 patients who had smaller HER2 positive breast cancers that were lymph node negative, in which patients received the combination of chemotherapy in the form of paclitaxel or Taxol, along with trastuzumab. They received this combination for a total of 12 weekly therapies. And then patients received trastuzumab or Herceptin every 3 weeks out to a total of a year. And this represents now relatively long-term follow-up. And what we know is with relatively long-term follow-up is that very, very few patients recur. And indeed, now we have patients who are 7 or 8 years out from diagnosis. Somewhere in the range of 97.5% of patients have still not suffered a relapse in the patients who were entered into this trial. And indeed, the likelihood of having a distant recurrence in this trial is very tiny. It's roughly 1% or so. Now, we've reduced therapy at the lower end of risk factors for HER2 positive disease. But how about those patients who are at higher risk? Well, one approach has been to say, let's add another antibody to trastuzumab. Trastuzumab, again, is also called Herceptin. The antibody we've added is Pertuzumab. You also may have heard of this as Perjeta. This has now been looked at in fairly large phase 3 trials. Most important of these is a trial called the APHINITY trial, in which patients were randomly assigned to receive chemotherapy and Herceptin, or to receive chemotherapy and Herceptin and the second antibody, Pertuzumab or Perjeta. And what we see in this trial is that while there doesn't appear to be any significant addition in patients who have lymph node negative disease, there is a significant addition for patients who have lymph node positive disease, where we've seen a further roughly 28% relative reduction and about a 4.5% absolute reduction in the risk of recurrence. And these curves are still spreading apart, so we may see further differences going forward, and we're still looking in these trials to see how much ultimate effect we'll see in terms of both distant recurrence and overall survival. Now, there's another group of patients who we also have great concern about, and these are patients who received so-called neoadjuvant or preoperative chemotherapy and Herceptin. We give this preoperative therapy both to kill the distant cancer cells that may have spread outside the breast, but also to shrink large tumors into small tumors so that we can more easily do surgery and indeed in many cases do breast preserving surgery. Sometimes, however, when we go in for that surgery, what we'll find is that the patient still has significant amounts of disease in her breast. And in that setting, we now know that another HER2 targeting agent, what's called TDM1, may be helpful in terms of lowering that patient's risk of having a distant recurrence of her cancer. So if a patient goes to surgery and has significant residual disease in her breast, we'll now offer TDM1. TDM1 is a clever drug. The T in TDM1 is trastuzumab or Herceptin. It's the antibody that we use for most patients with HER2 positive disease. But you can take that antibody and you can add a poison to it, a so-called plant poison. That's the DM1 that one sees here. Inject it into a patient. The Herceptin will then carry that TDM1 to the cancer cell. It'll be absorbed inside the cancer cell, release its poison, and kill the cancer cell. This keeps the other normal cells in the body relatively free of damage, at the same time increasing our ability to kill the cancer cells and lower the risk of distant recurrence. And this has now become a standard therapy in the last few years. Well, let's move on to triple negative breast cancer. And again, these are the cancers that are estrogen receptor negative, progesterone receptor negative, and HER2 negative. And I guess to summarize a very long literature, chemotherapy is potentially curative in the adjuvant setting. Many patients with early stage triple negative breast cancer have their disease cured with chemotherapy, but not all, unfortunately. This is the area of breast cancer where most patients who have a BRCA1 mutation, where their cancers live. These are genetically complex cancers. They have a higher mutational burden than most estrogen-sensitive cancers. And this turns out to be important therapeutically, as we've now learned. Now, I've always disliked the term triple negative because it doesn't really tell you very much about what's going on in the cancer. Imagine I'm looking at a woman in this audience and I see that she has red hair and I'm asked to describe her and I say non-blonde, non-brunette, and doesn't have a beard. That's kind of what we're saying when we say triple negative. But what we really want to say is she's a redheaded woman. We want to be able to define what's going on with that particular cancer, because it's by defining what's going on that we can actually lead to new therapies. One of the new therapies that's coming along, and one that medical oncologists have been relatively excited about because it's important across many different cancer types now, not just breast cancer, is immunotherapy, and in particular something called checkpoint therapy. And checkpoint inhibitor therapy got these two gentlemen a Nobel Prize just 2 years ago. And the basic idea here is that the body has immune defenses, so-called T cells. These T cells will swarm over the cancer cells, as you see here, the pinkish cancer cell with all these lovely blue T cells that are swarming over it. But cancer cells are pretty clever. And what cancer cells are capable of doing is to tell the T cells to go away. And for those of you who, like me, are a Star Wars fan, I'll briefly show this.
Let me see your identification.
You don't need to see his identification.
We don't need to see his identification.
These aren't the droids you're looking for.
These aren't the droids we're looking for.
He can go about his business.
You can go about your business.
Move along.
Move along. Move along.
And that is what a cancer cell does to the body's immune system. that's looking for it. You can move along. Don't worry about me. I'm really not a problem. And what we've learned recently for patients with large triple negative breast cancers, or that are still early stage breast cancers, is that if we add drugs that now awake the body's immune system to attack the cancer cell, in essence, to unleash the T cells on the cancer cells, that can significantly improve our ability to kill cancer inside the breast and increasingly outside the breast as well. And this represents one of the major advances for early stage triple negative breast cancer that we've seen in recent years. Now, we have many other new therapies coming along for triple negative breast cancer and indeed for other types of breast cancer. This is an exciting period in the history of breast cancer. Over the last decade, we've had more than one new drug per year approved by the Food and Drug Administration for the treatment of patients with breast cancer. Many of these drugs are now entering early stage breast cancer, where they have the potential to significantly improve our likelihood of curing patients with early stage breast cancer. That's an exciting thing for, I think, both for physicians and for patients. And with that, I'll come to an end, and thank you all ever so much. And I'd be delighted to answer any questions that anyone might have.
Wonderful. Thank you so much, Dr. Sledge, for that great overview of early stage breast cancer and the progress that's been made. We do have several questions, so we'll get started with that. Can you talk more about what the side effects of those CDK inhibitor drugs are that you discussed?
Sure. Some of the side effects kind of make sense, because when we give these agents, what we're trying to do is to inhibit cell proliferation. And so in addition to inhibiting or shutting down cell proliferation by breast cancer cells, we also can be interfering with cell proliferation in other cells in the body. And most importantly, white blood cells that are being produced by the bone marrow. So some patients who receive a CDK4/6 inhibitor will have a lowering of their white blood cell count and a slightly higher risk of coming down with a bacterial infection. This is pretty rare. And we can adjust for it just simply by measuring blood cell counts and then adjusting the dose of the drug. But it's still something that physicians need to watch out when they're caring for a patient and using a CDK4/6 inhibitor. Now, abemaciclib, the drug that I mentioned, that the recent trial shows a positive result. Also, in about 1 patient in 10, that patients will have a significant degree of diarrhea. Again, this is pretty manageable. We just lower the dose of the drug. We give an over-the-counter anti-diarrheal medicine, and that takes care of it for the great majority of patients, but again, something that we need to watch out for. These drugs also can cause mild fatigue in some patients, and occasionally we'll see patients who will have some mild hair thinning as well.
Okay. We have a couple questions about the use of genomic assays or oncotype testing for ER-positive cancer. So why would you get one test done over another, say oncotype versus mammoprint? And can you expand on how the recurrence score translates for premenopausal women specifically?
Sure. Okay. Well, let me answer the earlier question first. Which assay to use has largely been a physician's choice. And I think in many cases, it depends on where one is trained and what one's comfortable with. We have large randomized trials for both the mammoprint assay and for the Oncotype DX assay. I tend to prefer the Oncotype DX assay because I believe it gives me a little bit more information about which patients actually benefit from chemotherapy. Both assays are very good at telling you what a patient's risk of recurrence is, but I think the Oncotype DX is the one that's best at telling you which patients benefit from chemotherapy. Now, in younger women, in premenopausal women, the large trial that was done, the TAILOR-X trial, and it's a conflict of interest statement. There's a fellow named Sledge who's an author on this, one of the authors on this trial. In this trial, we looked at a relatively large number of women who were premenopausal and estrogen receptor positive. And there what we saw is that if a woman had a higher, what we'll call a high intermediate recurrence score, and it's very technical, but a recurrence score between 21 and 25, and she was under the age of 50, that woman appeared to derive some benefit from chemotherapy. And that is to say, roughly about a 6% reduction in terms of the risk of having a distant recurrence. And so there's still a population of women with intermediate recurrence scores where I think it's reasonable for a physician and a patient to discuss whether or not chemotherapy is the right thing to do there. This represents a relatively small minority of patients with ER-positive breast cancer, but it's still an important consideration and certainly one that is important to for doctors to share with patients.
Great, thank you. We have some questions about hormonal treatment for ER-positive breast cancer.
Sure.
So one question is, are there studies or recommendations on how long to be on tamoxifen before changing over to an aromatase inhibitor, based on going from premenopausal to postmenopausal status during treatment?
Mhm. So that is a great question. So again, first thing to say is that we don't use aromatase inhibitors in premenopausal women. So the only time we use an aromatase inhibitor in a younger woman is if we have shut off her ovaries with what's called an LHRH agonist, or the woman has had her ovaries removed. So for many premenopausal women, if they're young enough, they might receive tamoxifen for a fairly prolonged period of time. We have pretty good evidence now that 10 years of tamoxifen is better than 5 years of tamoxifen in terms of preventing recurrence and death. Now, similarly, if a woman has been on tamoxifen for 5 years, which in the past we considered standard, we have randomized control trials that say that particularly for higher risk women with larger tumors or lymph node positive disease, that those women get substantial benefit for 5 years of additional aromatase inhibitor therapy. We have a number of studies that have already looked at women who start with an aromatase inhibitor. And in the past, we gave these women just 5 years of therapy. We now have studies that are looking at 10 years versus 5 years. The initial data from those trials, I would say, isn't hugely impressive. We're not quite sure that adding an additional 5 years in aromatase inhibitor to an initial 5 years adds a whole lot. Though I'll qualify that by saying that we don't think we followed the women in these trials long enough to be sure.
Thank you. And sort of on that same subject, what are your thoughts about using ovarian suppression for premenopausal women, especially women who are maybe at sort of an intermediate risk, say an intermediate OncoScore, no chemo, or low clinical risk?
So the best way we've looked at this has been in two linked trials called the SOFT trial and the TEXT trial. SOFT is one of my favorite acronyms. It's Suppression of Ovarian Function Trial. And this was a trial that randomly assigned women either to receive 5 years of tamoxifen or to receive 5 years of tamoxifen along with ovarian suppression, chemical ovarian suppression, or to receive an aromatase inhibitor plus that chemical ovarian suppression. And what we found in this trial is that if you belonged to what was considered a high-risk group, and this was defined in this trial being a very young woman age 35 or under, or alternatively a woman who's at somewhat higher risk, say a woman who would have received chemotherapy because her physician thought chemotherapy is warranted in that setting. There's pretty compelling evidence there that those women get substantial benefit from having ovarian suppression in addition to endocrine therapy, and that probably the best therapy there in terms of giving the best results is when an aromatase inhibitor is combined with ovarian suppression. Now, big qualifier here. That trial was done before we had any data for Oncotype DX or MammaPrint. And so today, with that sort of data, we might come to a very different result. And indeed, if a woman has a low recurrence score, or increasingly one of the intermediate recurrence scores that we've talked about, and as a younger woman, we might well avoid chemotherapy in that patient, and we certainly might well avoid giving ovarian suppression in that patient as well. It's somewhat of an unanswered question. It's one of those things that oncologists argue about at meetings. But in general, I think the gestalt the physicians have is the higher the risk, the more the complete endocrine suppression that one should do. Now, the other qualifier here, of course, is these menopausal symptoms. They include issues such as bone loss, potential cognitive concerns. All of these are issues that are come to the fore when one does ovarian suppression in a younger woman. So again, these trade-offs have to be discussed by a physician with a patient. Thank you.
Great, thank you. And what about the use of hormone therapy in borderline ER/PR positive, or now so-called ER low or PR low?
Yeah. So I would say that the evidence that we have is that clearly the stronger your estrogen receptor content in your tumor, the more likely you are to have benefit. And similarly, being progesterone receptor positive probably also increases your benefit. In contrast, if one has a relatively low estrogen receptor content in one's tumor, let's say a ER of 3% or 5%, what we still consider estrogen receptor positive, there may be a smidge of benefit for those patients, but it's not a whole lot. So when I have a patient who has a very low estrogen receptor content, that's a patient who I'm more likely to recommend chemotherapy to. That's a patient who's more likely, for instance, to have a higher oncotype DX recurrence score, a higher mammoprint risk of recurrence established. So they're more likely to be offered chemotherapy. And I'll also tell that patient that while they may gain some benefit from hormonal therapy, that benefit's probably going to be lesser rather than greater. I will still offer it, and particularly for higher risk women, I will definitely encourage it, but I'll do it with that real proviso.
Thank you. We have a few questions about HER2 positive breast cancer. People are wondering generally with the new regimen you discussed, whether there is any role for carboplatin any longer, or what is the standard of care for HER2 positive breast cancer?
Yeah. So I will say that certainly the most common adjuvant regimen that I use for a lymph node positive patient today, who's HER2 positive, is what we call TCHP, and that's Taxotere, carboplatin, Herceptin, Perjeta. That is the regimen that was used most commonly in that APHINITY trial that I mentioned. And it's one that we certainly have exceptional results with in the metastatic setting as well. So that's the one that we were most likely to use, certainly in my clinic. Now, a qualifier there, we've never actually done a trial of Taxotere, Herceptin, Perjeta versus Taxotere, carboplatin, Herceptin, Perjeta. So I'm not sure that we know for a fact that the one is better than the other. But it's still certainly one that's used quite commonly by physicians.
That leads into another question someone had about Perjeta, which is that given the challenging side effect of diarrhea with Perjeta, can it be avoided? But it sounds like you're a fan of it.
Well, again, I'm a partial fan of it. I don't think we don't have any evidence, for instance, that patient who is lymph node negative. In fact, the data that we have at present would be to the contrary, that there's no obvious evidence for additional benefits. So trastuzumab alone in that setting is certainly very reasonable. And indeed, if I have a lymph node negative patient, particularly one with a smaller tumor, I will routinely recommend 12 weeks of Taxol and trastuzumab, and then trastuzumab out to a total of a year worth of therapy, without any more in the way of either chemotherapy or. I think when one gets past that, we're of course balancing risk and benefit. There appears to be a real benefit in lymph node positive patients, but it's a modest benefit. So it's a few percentage points. So I think it's certainly reasonable for a patient to weigh in her mind is, do I want to pay the price of toxicity to get the benefit that Dr. Sledge has talked to me about? And of course, patients will vary considerably on this. Now, the diarrhea, the GI toxicity that one sees with Perjeta is real, but it's not all that common. And when it occurs, it's frequently treatable with very standard, very well tolerated anti-diarrheal medicines. So we can frequently take care of it pretty easily. Again, I think, as in everything that we do in oncology, there's two experts in a room. There's an expert on the disease and there's an expert on the patient. And those two experts got to agree before you go ahead with therapy.
Absolutely. I think that's a great perspective. What are your thoughts on the use of the now approved biosimilars for trastuzumab? Are they just as good for treating HER2-positive cancers?
I think everything we know would say yes. These have been very carefully looked at by the Food and Drug Administration. They've been looked at in relatively good-sized trials in the metastatic setting. They've not been looked at in the adjuvant setting, though we have no particular reason to believe that they would be any different there. And so they've been, I would say, increasingly taken up by physicians, and more importantly, taken up by the hospital systems, just simply because they significantly reduce the cost of therapy. By biosimilar, what we mean, these are antibodies that are produced in living cells and then are basically harvested and purified. There can be very small differences between one batch of antibodies and another batch of antibodies that are targeting HER2. So you go to pretty extreme measures to try and prove that these are similar, hence biosimilar, and decent measures to prove that they're as active in the setting of advanced disease. And I think most of us are comfortable that they are.
Great, thank you. And we have a question about what is the current standard of care for triple negative node positive breast cancer?
So I would say for most of us, the standard of care would be in the adjuvant setting, has been dose-dense chemotherapy with adriamycin and Cytoxan, followed by a taxane, usually Taxol. Therapy being given every 2 weeks for a total of 8 cycles of therapy, 4 and 4. Now, the areas where I would say that there's still controversy, one we've already discussed, and that's the use of platinum-based drugs. There are some studies, particularly a fairly large one done in Germany, that suggests that adding a platinum-based therapy adds benefit. I would say beyond that, I've already mentioned at the very tail end of my talk, the use of checkpoint inhibitors, the new immunotherapy drugs, in the neoadjuvant or preoperative setting, where we have a fairly large study that says that there's a significant improvement in terms of what we call the pathologic complete response rate. Pathologic complete response rate means when I give someone therapy and then I go to surgery, if I find no cancer in the lymph nodes and no cancer in the breast, that's a pathologic complete response. Those patients historically do exceptionally well. And the data that we have from the fairly recent large study that was done in this setting is that giving preoperative checkpoint inhibitor therapy along with chemotherapy improves the path CR rate by about 15%. Pretty significant step up. We're still waiting for longer term data from that trial in terms of risk of distant recurrence and risk of death. That data will take some while to come in. But certainly that's looking positive, and we hope that that's going to be a real step forward. Now, again, the qualifier here, these checkpoint inhibitors have real side effects. These are drugs that are unleashing the immune system. And when you unleash the immune system, when you unleash T cells, one can see real toxicity. The standard toxicity is what we call itis. Itis is inflammation. You can see pneumonitis, inflammation of the lungs, carditis, inflammation of the heart, gastrointestinal itis, colitis, inflammation of the colon, dermatitis, inflammation of the skin. You can see hypophysitis. This is affecting the endocrine glands. So one can, for instance, become hypothyroid on these drugs. And these are real side effects. So again, physicians need to be very careful about which patients these drugs are going to be used in, and also much more careful about monitoring patients while they're undergoing therapy.
Thank you. You talked a lot about de-escalation of systemic therapies, but we have a question regarding lymph node surgery. Do you know if there are other options of lymph node assessment, such as MRIs, that are being studied as an alternative to sentinel lymph node biopsy?
Sure. We've looked fairly extensively at MRIs, and MRIs are reasonably good at telling you whether or not there's lymph node involvement or not, but not perfect. And they're not perfect because they're just simply not capable of picking up microscopic disease in a lymph node. Now, we also have studies that have suggested that if you compare patients who've had a sentinel lymph node biopsy, and let's say they have one positive lymph node, and then you compare doing further lymph node resection to just stopping with the sentinel lymph node biopsy, it doesn't appear to have a negative effect in terms of long-term outcome. So at least for some patients with what we'll call minimal lymph node involvement, we can probably get away without doing a whole lot more in the way of surgery.
Okay, and I think we have time for one final question, which is what sort of follow-up testing is recommended for early stage breast cancer? How would you detect a distant recurrence?
Yeah, so the current answer is as little as possible. And that is to say, while we have PET scans and CAT scans and bone scans and dog scans, we don't have that one yet, but all these particular scans that we have that we use to monitor advanced disease, none of these scans are particularly good at picking up early recurrence of breast cancer. And so they're not currently recommended as a means of following patients with early stage disease. Now, what may change over the next few years, I strongly suspect, though we don't have perfectly compelling data yet, is that new technologies such as circulating tumor cell measurements or measurements of so-called circulating tumor DNA, these two collectively we've lumped together as liquid biopsies, might allow us to detect early recurrences of breast cancer. And by doing so, might allow us to give therapies that will prevent that microscopic disease from turning into the classic 900-pound gorilla. And those new diagnostic techniques, I think, are a source of real excitement among breast cancer researchers. And hopefully over the next few years, we'll get stronger data that will justify their use.
I agree. I'm optimistic about that as well. So with that, we will thank you again, Dr. Sledge, for your time and expertise. It was a wonderful talk, a wonderful session, and thank you, audience, for the great questions. I'm sorry we did not get to them all. It is now time to navigate back to